What? Well, okay. Oh. Hello, everybody. We start in 10 minutes. Ooh. Oh my God. Hey, Warlock.
Hi, John.
Hey, good morning. How are you?
Good evening from here. I'm good.
Okay. How was your work today?
Too. My work today, it's so nice days today. Today it's a endovascular day.
Oh, okay. So that's your favorite day, right?
Yes, feel good to be under radiation.
Do you have your camera working?
Oh yeah, sure. Hold on.
Okay. I'm trying to get Vlad. Vlad's here. Vlad Bennett. Damn. Can't get him in. I don't know why. There you are.
Yeah,
How you doing?
I'm good. Take like after tooth extraction, so it's better today.
Oh yeah. When I saw you the last time, you were kind of like going like this, holding your cheek. I thought, geez, is something wrong with her? Because that's why I say, when you examine a patient, if you're in the same room, you can see little things like that. Just little things that
Oh,
people do. You know how it is. You do it all the time. I'm
um,
sure. I'm
yeah,
sure. When you walk in the room, you just see all these little things that you don't really notice, but you notice them. You know what I mean? And you notice that something is
yeah, like,
odd, is different.
yeah,
I'm sure
yeah.
you're good at that. So, yeah, uh, yeah, Ives conference went well. Well, lot of turnout, people from all over the place, and he put that together pretty quickly, within a couple of weeks. That's kind of the benefit of this platform. Is it still sore?
Uh, Not really. Actually, I think I take too much medicines now.
Too much motion.
Yeah, I take painkiller every 4 hours. It's not good, but yeah, I have to do it.
Yeah, yeah. Dental pain's the worst.
Yeah, worst.
Yeah. You know,
Especially, yeah, I used to have that experience of tooth extractions before, so I tried to inform my dentist this time that please inject lots of like lidocaines or painkiller. Like I don't want to feel anything.
oh yeah, I'm sure it's a common. As a kid, we had a dentist that didn't believe in giving lidocaine to kids.
Really, that's worst. Oh
Oh,
my god.
it was all these kids are screaming. You can imagine as a kid going into a dental office and hearing people scream all the time. It is Dr. Coffee. I still remember him. Just not believe in anesthesia. Okay.
But lucky that it's not swollen much. I that I told you that the dentist put a drain in there in here too, so it's
Yeah,
weird.
that's
A little
weird.
bit weird.
Was it an abscess? It must have been a draining abscess, huh?
She said that it's for hematoma.
Oh, okay.
Hi, Dr. Ortiz.
Yeah, you can keep your eye on the chat if there's questions or whatever.
Okay.
Okay.
I think it should start in 1 minute or something.
Yeah, yeah. IP's coming in a second. Yeah, we'll get started straight away when he comes in. I just sent him the link. So have people been seeing you at the hospital online?
Me?
Yeah.
See what?
See you on the internet.
Oh, some I tries to told them, but yeah, as you know that they do not really see me
Yeah.
much, but I'm happy to do it. Like, yeah.
Okay. I think Vlad was trying to get. Vlad, are you there? He was trying to get in. Send it to IPE too.
How's everything's going there? The COVID vaccine just launched, so they have any like?
Oh, it did. It officially launched, huh?
Yes, by Pfizer. I think that more promise than like Chinese or Russia.
Oh, I haven't really been following that. So it's just released, right? I'm sure it just happened, right?
Things say this new been launched for like a couple of weeks now, so like it's a good news. I think the intention is to launch after you get your new president. Yeah.
Well, it was
Yeah.
so odd that 3 days after the president, all of a sudden it's available. It just was very odd, that it wasn't before, the election. It was very odd.
I think, but I believe that for the fronts, for first group of people that will get the vaccine should be maybe the doctor or the nurse or the person like healthcare people.
Yeah, that's probably what they're doing, right?
Yes, normally like that. But yeah, I just feel that we are also like a experiment rat too. So like just for the doctor inject that first.
Well, I watched this documentary on a drug trial they had that was rushed through, and it was a complete disaster. I mean, people got ill, very, very ill. I think some people died. And they just injected the full dose to like a bunch of people. It was in Europe. It was in Europe. Yeah, look it up on Google. Drug trial deaths. I think it was France or something like that. It was a disaster drug trial.
Jeez.
Where's I?
He's here?
Not yet.
I got to. I gonna alert my friends, my other friend. Like I'm here to. Hey, about the Singapore webinar.
Yeah. You can come to that too.
Yeah.
Huh?
Like one of my teachers just post that and advertise that on the Thai societies too. So yeah, it's successful a lot. Yeah.
I'm sorry, I wasn't listening to you. What'd you say?
For the Singapore webinar.
Oh, okay.
Dr. Ben is here.
Oh, Vlad, are you here?
Yes. I saw him. Yeah.
Oh, okay. You met Vlad, right?
Yeah, of
Oh,
course.
can't click on the
Hey,
video.
Vlad. Vlad,
Hi, John.
how you
World.
doing? I'm glad you came.
Yes. We
John,
have a free day today.
John,
Oh.
I is here, so he asked me to admit him.
Yeah, I did.
John,
Warlocks is getting bossy.
Okay.
I don't know. Warlocks is getting bossy. I don't know.
The genetics.
No, she merits it, John. She merits it.
Oh, I know. Okay,
make no mistake.
You ready to go? Oh, I guess I must be. Are you there? Right? Yeah, bandwidth is not too good, I guess. Hopefully it'll work out.
Hello, John. Is
Yeah,
it okay?
yeah. I guess your bandwidth's not too good. That's okay. Okay, you ready to start?
Oh, yes.
Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach in Florida. We have the pleasure of, for neuroanatomy, we have the pleasure of having Ike Cherry in that's going to give a lecture on cranial bases, anterior, middle, posterior, and approaches. Okay, Ike, welcome. It's all yours. It was
okay.
Okay.
He's frozen.
Yeah. Frozen. Yeah. Just be patient. I think he's at a new place. In Krishna, because his other Wi-Fi worked pretty good at Bharatnagar. So how you been? How you been, Vlad? What have you been doing? A lot of conferences.
We've got lots of virus, but we are running still normal service. But there are less patients since people are afraid to go to the hospitals, so they don't get diagnosed.
Is it getting worse in Czechoslovakia?
It's getting better now. It's getting better, but it was really, really bad for a while, for some 3-4 weeks. Now the numbers are decreasing.
Oh, okay, good. Yeah, Warlocks was just saying the vaccine is available.
Yeah,
is it available in Thailand now?
Or no, I think that it's just announced. They just make an announcement, but I don't know that they distribute it to the normal people yet. But I heard from some people who work there, they say that they're gonna distribute the first lot to the maybe doctor or a nurse who have to face those cases first.
Yeah. Oh, okay. You know, when I introduced IPA, I forgot all about your Warlocks. We'll do it again. We'll do it again, okay? Because we'll have take 2.
It's fine. I still stuck with you. We still have to do a lot of webinar anyway.
Hey, I was thinking you should have a signature little gesture that you give, like wiggle your nose or something like that. Can you do that? Can you wiggle your nose?
No, it tries to be more like.
You can't wiggle your nose like a signature that you'll be known for, like wiggling your nose or something.
No. Now I try to have less smile because some people don't notice that I'm neurosurgeon. So yeah, try to.
Oh, okay. Yeah, Ike's working on the internet, so be patient. He's doing something. You just noticed. You know what I mean, right? You remember the Bewitched, the TV show Bewitched?
It's old.
That's old. Did you ever see it?
Yeah, I see that, but it's old.
Well, I know, but do you remember that she used to wiggle her nose?
I'm not going to do that.
Try it. Can you try it? Just try it.
No.
Okay. Or something else. I don't know. That's something that you'll be known for. That people see you on the street, they'll wiggle their nose or do something.
You know, it's really difficult to be an Asian woman and work as a surgeon because most of the patients don't think that you are surgeons. So
Yeah, I know. You say in the hospital or everywhere?
Everywhere, actually.
Really?
Then normally they will walk past me in the ER. So I just have to call them back. Yeah, I'm here. Talk to me.
Oh, okay. Yeah. You were saying they think you're in the maid and stuff, and in the hospital they think you're cleaning up. That's true, right? They think you came to clean the room.
They think I'm an externship or something. Okay, I'm here.
Okay, we'll start again. Okay, let me. IP there?
Yes.
Yes,
Okay.
I'm there, John.
Okay, we'll start again. Okay, anytime, Warlocks, go ahead. Go ahead, Warlocks. Introduce me.
Okay, so hi, it's a neurosurgical TV. So today we have the topic.
Neuroanatomy TV.
Neuroanatomy TV, sorry.
That's better.
Okay, so it will be about cranial base, anterior, middle, and posterior approach by Dr. Shirans. Okay.
Thank you.
Right, can you see my screen?
Yes,
yes.
you can see.
Yes, we see that.
Okay, so before we talk, I'm going to minimize this. You know, cranial base is a wrong term. You can hear me?
Yes.
What I'm saying is skull base is a wrong term. It should be brain base. The whole objective of getting into the base of the brain, where all the vessels, the nerves, and all other important structures are, is the objective of skull base surgery. Now, how you do that is by certain maneuvers. And these certain maneuvers, they depend on adequate removal of bone. They depend on unfurling the brain. You know, it is like a flag which is all, let's say you have folded a flag. Now you want to unfurl a flag. You need to have some maneuvers depending on how the flag is folded. So removing enough bone and unfurling the brain, or in other words, unlocking the brain, is how you will get into the skull base. Now, if your objective is to get into the anterior skull base, which means optic nerves, carotid, third nerve, anterior suprasellar cistern, then a simple sphenoid ridge removal would suffice. But supposing you say you want to get lateral to the third nerve and go posterior into the interpedunculaire cistern, you will need to do a pericavernous dissection because you need to get the temporal lobe out of your way. That way, if the temporal lobe is slowly shifted out or unlocked, that is called axial unlocking, you can unlock the temporal lobe away from the cavernous sinus. This is not actually giving you an access to cavernous sinus, but it is also widening your corridor lateral to the third nerve all the way up to the interpedunculaire system. Now let's say you want to go to the lateral aspect of pons. Then you have to come under the temporal lobe, remove the anterior petrous portion, the bone which can be safely removed from carotid to all the petrous ridge, from V3 to cochlea, all this bone can be removed, and then you are on the lateral aspect of the pons. So I'm telling you how to get into the anterior aspect, then the lateral aspect. And if you want to go posteriorly, you can do a posterior petrosectomy. That is nothing other than a mastoidectomy and also removing the semicircular canals and pulling the sigmoid sinus a bit back to get into a window that is very oblique but posterior to the fifth nerve. And then if you want to go lower, further lower, like yesterday, the dissections what we did, we can go for a far.
Excuse me,
please, Aisha, we don't. Okay.
The slide is not. Excuse me, Neru. The slide's not moving.
John, the slides are not meant to be moving. The slides, I am just giving an overview.
Oh, okay. I'm sorry.
Okay. Thank you.
Okay.
Don't worry. The slides are not meant to be moving. What I'm saying, please carefully listen to it. What I'm talking to the other people is that what exactly is the meaning of skull base? I mean, without knowing the meaning of skull base, then there's absolutely no point of anybody to see all these procedures. That's what I'm saying. So I'm telling you how to access the anterior skull base, how to access the middle skull base, how to go behind the pons, and how to come far lateral or extreme lateral or enough lateral, as Vlad and Juha says. Now, having said that, our objective today, as many times we have done, is anterolateral skull base. So here we have started this dissection. You can see the frontal lobe here. Can you see? Everybody see this? Everybody see this?
Yes.
Yes?
Yes.
That's the frontal lobe. That's the orbit. That is the bone which is over the superior. Anybody? Above, what bone? What is the lateral? What does this bone form the lateral limit of? Anybody? Please keep yourself unmuted when I ask you questions and keep on answering this. What is this? What is this temporal lobe that I am going to strip it from? And when I strip it from, the cranial nerves will start to be seen here. And what is that structure? What fissure? Anybody?
Okay, Neru, let's go.
Superior orbital fissure.
Okay, sure.
Yes,
Wall of Tauna sinus.
Yes. And what is this structure which is on the junction of frontal lobe, temporal lobe, and superior orbital fissure? What is that?
Orbital band.
Yes, the meningo-orbital band. Right. So you see, you have to expose the frontal lobe, temporal lobe, meningo-orbital band, and you are now dissecting. This can be done in the cadaver and it can be done in live surgery also. So right now what we are doing is we are gently dissecting. Can you see? That is the lateral limit of the superior orbital fissure. And if I remove this bone, I can get into the orbit along the superior orbital fissure. Are you understanding me? Everybody?
Yes, we do.
Yes, we can. Yes.
Right, thank you. So that is the orbit, and this bone is guarding the superior orbital fissure. So if I remove this bone, I can get from the cavernous sinus to the orbit. You see? So that is how tumors also get in from the cavernous sinus to the orbit. So that part we have to remove sometimes. Now what is this part that I am removing from the cavernous sinus? I mean, that is a cavernous sinus. Anything behind the superior orbital fissure is a cavernous sinus. So what am I holding? I am holding the tempora and dissecting it away from the cavernous sinus. Are you understanding me? Is it very clear?
Yes.
Yes. Right. So once you know that, then you can also start doing it. Now, superior orbital fissure will be seen along this line. And if you follow along this line, you will see the V2 also. Now, the cranial nerves are not so clear. And this is how you want to keep it in a live dissection or in a surgery. This is how you want to keep it, because this membrane has to be kept. If you don't keep this membrane and if your cranial nerves are seen, that means if it is live surgery, you are going to be having a lot of bleeding. So you don't want to do that. So you are keeping this membrane and slowly dissecting this away from the temporal lobe, away from this membrane. And now you are incising the orbitomeningeal band, which is at the junction of the frontal lobe, temporal lobe, and the superior orbital fissure. You can dissect it all the way up to the superior orbital fissure. Okay? Those of you who watched the dissections that we did day before yesterday, where we did the same thing, it is the same anatomy, and it is the same anatomy that you will use for most of your anterolateral skull-based cases, your aneurysms, your tumors, and many more things. Okay. So this is how you're going to dissect it now. Hello?
Yes, we are hearing you.
Yeah, I'll call you later. You see that? Hello?
Yes.
Everybody, can you see that?
Yes, we are following you.
And now you see, when I am cutting off that orbitomeningeal band, you see what I am exposing there? What am I exposing there? What is that?
Anterior clinoid.
Clinoid process.
Yes.
Anterior.
Yes, the anterior clinoid process. See how this junction, which, one second. Right. So you see how this junction of the temporal lobe, frontal lobe, and the orbitomeningeal band, once I cut this, you see how this junction folds away. This junction folds away from it completely folds away from the clinoid process. You see how easy that becomes. You see this entire junction falls back, and the cavernous sinus is much easier to dissect, and the anterior clinoid process, or the clinoid triangle, it starts getting exposed. Is this very clear, everybody?
Yes, I thank you.
Yes or no?
Yes.
Right.
Yes.
Once you understand that, Once you understand this process, then I am going to further dissect the temporal lobe away from the cavernous sinus, and we will expose the entire cavernous sinus now. Okay, this is very easy. This is nothing very difficult, you see. So we are going to do that now. This is a pericavernous exposure. You will be able to see the fourth nerve taking shape, probably the V1 there. Through the membrane you can see, because third nerve is always medial, slightly medial, underneath the clinoid process. So third nerve you will not be straight away seeing it, but you will see the fourth nerve and you will see the V1. So we are going to, and lateral to the third nerve, there will be always the tentorial dura attachment, or the clinoid process, there is tentorial attachment. So that dura has to be incised off. Otherwise, when you take the clinoid process, you will have to pull and push and everything. So if you sharp dissect that dura off, and the clinoid process is completely free. Okay, you will see that was the attachment where that dura was getting attached to the tip of the clinoid process. Now you just displace the fourth and the third complex away from the clinoid process. See that? So the inferior part of the clinoid process is also free. Can you see that, everybody? Yes, or no? Are you understanding?
Yes.
Yes.
Now I am going towards this side. I'll be going towards the extradural optic nerve. I'll be going towards the extradural optic nerve in this side. Okay. If I dissect the dura on this side, I'll be going towards the extradural optic nerve. I'll be able to see. Medial to the clinoid process, I'll see the optic nerve. Inferior to the clinoid process, I'll see the carotid. You should know all these anatomy very, very clearly. If you don't know, then dissection in this area, it becomes a nightmare. It becomes really difficult, okay? Because it starts oozing, you get into a different plane and you panic and things go wrong. Okay? So a lot of finesse, a lot of knowledge of anatomy, a lot of seeing these dissections, and a lot of doing this dissection. Now you can see the fourth nerve clearly. And the attachment of this dura to the clinoid. Now this is something I don't want you to do in a live surgery case. Okay? But you see how easily this clinoid is exposed and it is detached off. So I can take out this clinoid without any issues. You see? Now that clinoid is coming out. Because I have detached the lateral margin of that clinoid away from the ligaments. The medial margin needs to be detached. So I am detaching that also. I have to be very careful because the carotico-oculomotor membrane, which directly overlies the carotid, is there. So I have to be very careful. Now, that clinoid process is out. Okay? And my optic nerve will be there. And my carotid is going to be, extradural carotid is going to be there. When I opened the dura, day before yesterday, we opened the dura. That is the fourth nerve. That is a fourth nerve. That is V1. And you have optic nerve there. That is the optic nerve. That is optic nerve. You can see. Can you see the optic nerve, extradural optic nerve there? Everybody?
Yes.
Right. And that is the carotid.
We're losing the audio, I believe.
Yeah, can you hear me?
Now we can, yeah.
Yeah, I was not talking. That's why I was just watching and enjoying it. I was not talking.
Okay.
So that is why you lost the audio. Don't worry. Okay, John. So I'm drilling the optic strut now. That is underneath my optic nerve. See, this is my optic nerve. This is the optic strut which is anterior to the C3 turn of the carotid and underneath the optic nerve. Underneath, you must remember, extradural.
Well, Yuha's here. Yuha is here.
Hey, Yuha. It's a pleasure to have you.
And Vlad's here. Vlad's here too.
Wow. So the two titans are
Hi.
here, Vlad and Yuha. Hey, Vlad, good to see you. And Yuha also, great to have you here. I know I must have done this talk with you must have seen this for the 100th or the 1000th time, Vlad, but I guess it's interesting each time, even I see it, because probably I have some amnesia, that is why, but I enjoy this each time. I see it, I enjoy it. I hope you do the same. I'm not boring the hell out of you. So you can see the optic nerve there. You can see the carotid there. That's a carotid there. And that's a strut. That bone, that piece of bone between the optic nerve and the carotid, that's a carotid. I'm displacing the carotid down. And that piece of the bone is the strut. So we remove the strut and we come back to the cavernous sinus. And you see that the clinoid triangle is off. That bone is off now. Okay. So you can see the fourth nerve. That is the superior orbital fissure, where third nerve here, fourth V1 is getting into the orbit. That bone has been left. Now you can see the V2 and you can see the V3 and you can see that is the Gazillion ganglion. If you don't know about cystonostomy, then you can open this Gazillion ganglion and let out a piddly little amount of CSF and try to lax your brain. But if you know cystonostomy, you can open your dura right above the optic nerve. Here in this region, if you open the dura, you are right into the largest cisterns and you can let out a lot of CSF. If you think retracting this is going to be tough, you can let out a lot of CSF there in this region and you will be quite okay. So you can see the fourth nerve now, you can see the fifth nerve, V1 there, V2 there, V3 there, and that is a Gazillion ganglion. Okay. And the fourth nerve and the V1, you can develop a small window between the fourth and V1. Can you see the fourth nerve and the V1? So I am developing a window between the fourth and the V1. And that is the vertical portion of the carotid. When you develop a window in the Parkinson's triangle, that is between the fourth nerve and V1, you will see the paraclival carotid. That's the vertical part of the carotid. This carotid is going to go like that. Then it is going to come like that. That is the horizontal intracavernous portion. Then it's going to come up again. That is a paracellular portion. So what you're seeing right now is the paraclival portion of the carotid between the fourth and V1. And medial to V1, you can already see a peak of sixth nerve. Okay, this sixth nerve will go into the Dorellos canal. Okay, that sixth nerve will go into the Dorellos canal. So that is what you're seeing, a peak of that sixth nerve. So between that sixth nerve, once it goes into the Dorellos canal, then your anatomy of petroclinoid ligaments, petrosphenoid ligaments will come into play. Okay, that is important for removing your petroclival meningiomas. These ligaments are very important to remove, to get into this space. But let us forget that. Let us now see the sixth nerve that I'm hooking out from medial to V1. That is the sixth nerve. That is the sixth nerve. That is the abducens nerve. So you have V1, you have vertical segment of the carotid, you have fourth nerve there, and you have the sixth nerve there. Day before yesterday also I showed the same anatomy in the dissections. Okay, so this is the vertical carotid and you have the sixth nerve there. All right, and then now we are going between the V1 and V2, where you will see the junction between the paraclival carotid, and you can even see it disappearing into the foramen lacerum. So the foramen lacerum will come here, and your petrolingual ligament will come underneath this fifth V1, and then your carotid will turn here into the petrous bone, horizontal carotid. That also I will show you. That also I will show you. So now you have optic nerve, the paracellular, vertical paracellular carotid, C3 carotid, C4 carotid is like that. That is a horizontal segment. C5 carotid is like that. That is a vertical segment. And that is where the junction of C5 and C4 carotid is from where the meningohypophyseal branch comes. Okay, in the Parkinson's window. Now you are seeing the V3. That is the V3. And behind V3, I am developing the space there. Okay, that space is the Kawase triangle. So when you develop the Kawase triangle, you have to further push this dura, further the temporal lobe, you have to further dissect it back. So that is what we are doing right now. The temporal lobe dura is being further dissected, and now you have the V3 there, the petrous ridge there. Along the petrous ridge has the superior petrosal sinus. The superior petrosal sinus will run on top of the fifth nerve. So this is the Gazerian ganglion, and the retrogazerian fifth nerve will go down and superior petrosal sinus will go above us. Okay, you should know how to arrest the bleeding in the superior petrosal sinus. So what you can do is that you can open the dura here. Once you take out this bone, and this bone, you must remember the lateral boundary of this bone is the carotid. So we are going to show you the carotid very soon. You have the cochlea here. Okay, you should identify the meatal line. That comes with experience, but I'll tell you easy ways to identify this meatal line. And you see, that's the carotid. That soft tissue that you see there is the carotid canal. So you saw the vertical carotid here, and this vertical carotid is going to become the horizontal carotid. That is C6 carotid. Okay, horizontal carotid. So that is paraclival carotid, and that is petrous carotid. Okay, so you are going to see the petrous carotid there. So I have identified the petrous carotid. Once I have identified, see that I am moving that carotid away. Once I have identified that carotid, all this area, even posterior to the IAM, can be drilled away. Now I am moving the carotid away so that it never gets caught into our drilling region. So I am very, very sure about that carotid now. Okay, and you can move your V3 a little bit anteriorly, and you can see that is a vertical carotid, that is a paraclival carotid, and you can see the sixth nerve also going there. So now you can see V1, V2, V1 going into the superior orbital fissure. Okay, and then this is V3, and now that's a carotid there, and I am doing an L-shaped drilling. I'm doing an L-shaped drilling all the way back to the IAM. You will see the IAM also now. Okay. you will see the IAM, internal auditory meatus. So up to the internal auditory meatus, you can do this drilling. Okay, you can decorticate the cochlea. Here you can see that decorticating the cochlea. You can see the carotid here. The whole fifth nerve is in your way there, and the petrous ridge is here. So I am going to take away this bone till I completely see the dura of the posterior fossa. So that is the Kawasai's drilling. Okay, it's very, very simple. There is nothing to it. All you young guys, okay, instead of thinking about writing 100 papers, please do this dissection. Go to your places where you can do dissections and go do this dissection. Okay, WFNS, Neuroanatomy Committee, the neurosurgery coach, we all will be happy. Our objective is that all of you should learn this. Okay, it should not be to some select few. Now you can see the IAM dura already exposed. Can you see that transparent thing? That's the IAM dura. Okay, remember that's the IAM dura. So the IAM, once you get that, then you are safe to go posterior to it, anterior to it, except the cochlea in this region. You can decorticate the cochlea, but don't drill into the cochlea unless you really want your patient to be deaf. Okay, sometimes it's not indicated. Most of the time there's no need also. So no need to go into the cochlea. So you can. That's the carotid. That's the IAM. That's the petrous apex. There will be the true apex. Okay, you can remove all this bone. This entire bone you can remove. And instead of getting a small tunnel-like Kawasai, you can get a huge exposure there. People tell me, oh, Kawasai is not good exposure. Not wrong, because you make a tunnel-like exposure and you try to remove tumor through that tunnel, it is not a good exposure. You have to expose the carotid. You have to expose the petrous. You have to expose the IAM. Okay. All this if you expose, and if you can also mobilize this B3 anteriorly, you can drill around the foramen ovale and completely into the infratemporal fossa, and then completely displace this, this nerve complex anteriorly, and you can even take off the bone underneath the trigeminal impression. Okay, I mean the trigeminal impression can also be drilled, but you have to be careful about the carotid, because the carotid comes medially in this place. Okay, the carotid comes medially in this place and becomes the vertical carotid. Okay, the paraclival carotid. So you have to be careful about that. But otherwise, all this bone you can remove. Everything you can remove, and this is exactly where your petroclival meningiomas are attached. This is, if you remove them, and if you go, I showed you the vertical carotid there, the meningohypophyseal trunk is there, out of which is the branch which goes to the Casanari and Bernasconi tentorial branch. That is what supplies these meningiomas. You take that artery, you take this dura, you would have, paralyzed the petroclival meningioma. All right. And unless you do something very wrong, like pulling it out in one piece or something, then you have a very good window of getting into these tumors. Of course, you should learn how this area you should learn. This area is a little bit complex. So you have petroclinoidal ligaments, petrosphenoidal ligaments. Okay, you have the superior petrosal sinus. You should know how to open the dura here. Okay, that we will show you. All right. So now we are going to do this drilling completely. I'm not rushing through because I want you to see, I want you to see everything. So can you tell me what is that structure? Anybody? What is that structure? Who's going to tell me what is that structure? That's a carotid. Okay. That's a carotid. So we drilled out all that up to the posterior fossa. Lot of patient drilling required, and all that. Now you're going to open the dura. What you're going to do is, from the posterior fossa, you come above the fifth nerve, and then actually the fifth nerve dura can be opened like that. You know, you can be opened like that, and then it can be retracted forward. Okay? This dura can be retracted backwards. So you will see the fifth nerve, retrogazerian fifth nerve is going there, and you can see in front of the fifth nerve is there. So this will be the superior petrosal sinus. You need to, earlier we need to put clips. There is no need to put clips. You can use good bipolar. Bipolar, the superior petrosal sinus is possible most of the time. Sometimes it's not possible. That time you may need clips actually. So you are releasing the fifth nerve there. That is the first thing you have to do. Okay, release the fifth nerve. So this dura, you have to take it forward. Okay, and you can see the lateral margin of your pons, posterior to the fifth nerve. And you can see this thick arachnoid where your fourth nerve, once you cut your tent all the way down, you will see your fourth nerve, you will see your PCA, you will see your superior cerebellar artery. Okay, you can see in front of the pons, you can see that is a vertical paraclival carotid. Okay, vertical paraclival carotid. Remember that the artery Bernasconi casinari will go back like that on the tent. So you cut that tent, you take that artery off, then medial to the V1, you can see the sixth nerve going medially, and you can also see the Gruber's ligament and the pituitary ligament. You'll be able to see that. Okay, that you need to release this part. So there will be tumor sometimes there. Okay, that is the vertical carotid. And now you make a temporal lobe cut and then cut the dura. You will have a panoramic view, really panoramic view. Okay, all the way from second nerve. That's a second nerve. That's a clinoid. That is a paracellular vertical carotid. Then we have the third nerve coming here from the dura. I mean, third nerve can be released all the way. And then you have the vertical carotid, paraclival carotid. Okay, and paraclival carotid will go all the way underneath the trigeminal nerve. And now, what are you seeing? Do you realize what are you seeing? That is the seventh nerve. Okay, that's the seventh nerve because I have drilled the IAM and opened the IAM. This is the lateral margin. That's the seventh nerve. Okay, that's the seventh nerve. Sorry, this is the seventh nerve. Okay, and that is the fifth nerve. That is the fifth nerve. Posterior to the fifth nerve, that's the seventh nerve. IAM has been drilled. That's the IAM dura. And okay, that is the seventh nerve complex. So you see, second nerve, carotid, third nerve, fifth nerve, seventh nerve, frontal lobe, temporal lobe, orbit. Okay, once the dura is opened, you can see second nerve, carotid, third nerve going into the cavernous sinus. You will see fourth nerve coming here and going in, fifth nerve there, the pons there, lateral margin of pons there, anterior margin of pons there. Everything is seen on this exposure. Okay, now I'm going to stop sharing. How do I? Is that clear? Whatever we showed you, is that clear, everybody?
Yes, sir.
Is there any questions? I thought, I mean, see, we did a very, very small, very slow dissection so that you could see everything. You know, we did the same thing day before yesterday in Krishna Institute. And, you know, I wanted you to understand. Everybody should understand this. You know, there are no secrets here. You know, I should learn from you all. You should learn from us. Whatever our work is, you should learn from us. That's the only way we go forward. You know, we keep our secrets to ourselves, then we never go anywhere. You know, that is the beauty of this group, the WFNS Neuroanatomy group, which I really enjoy being part of this neuroanatomy group, because everybody there, you know, we do our work and we share it. So when we share it, we all learn. Everybody learns. And imagine now we have 61 participants. All of them will have something to share, or at least you should do something that you can share something. Okay. And when you share, what happens is the collective knowledge is much, much more powerful. The whole idea of democracy is that, you see. So you should be able to do that. Now, any questions or anything, any comments or anything that you have to say? Anybody? Yuha is here. Vlad is here.
They have a questions from the panelists on the chat.
Yes.
By the way, Shiva, she asks like,
Yes.
where is the greater pretorsal nerve in relationships to Kawase triangle, or maybe
lateralmost part of. See, you remember that I exposed the carotid.
Yeah.
In the Kawase triangle, I exposed the Peters carotid. Just above that, sometimes you have to section the GSPN to get into that area. So above the carotid, parallel to the carotid, is the GSP, the greater superficial petrosal. And lateral to that is the LSPN, the lesser superficial petrosal. Okay. I hope that answers the question.
Yeah. Okay, thanks for the question from Dr. Shiva. So is there any other question you can ask Dr. Ive? It's an open floor. So
any questions, comments?
Come on, guys, wake up.
Vlad?
No, everything's clear.
Thanks for coming, Vlad.
Welcome.
Is Yuha around still?
No, I think he stepped away.
Okay. Right. So anybody else? Any questions?
You probably should go to some specific diseases to show some tumors if you have material or aneurysms, just to get a connection between the anatomy of the approach, which is excellent and perfectly shown.
Yes.
But to show some clinical applicants. Can you do that?
Yes. I will show you right away. I will show you. So we will see. Let us see a live dissection. I mean, live surgery. Now, 1 second. Let me just share this.
Okay.
This will not take much time. And let me show you. Can you see now?
Yes.
Yes. Okay.
So again, like I showed you in the cadaver, so you have orbit there, you have the frontal and temporal lobes there, and you have the orbitomeningeal band. You see that?
Yes.
Exactly like you should. And that you are going to cut the orbitomeningeal band now. And you will see, once you cut, the clinoid process will be becoming clearer and clearer. That is, you can see the clinoid process there. Already seeing the clinoid process. So I am going to slowly take stitches and do the same thing, exactly the same thing. Okay. Now, temporal lobe and frontal lobe stitches. And then clinoid process exposure. That's a clinoid process exposure. That's a cavernous sinus. That is a cavernous sinus that I'm going to expose. Okay. That's a clinoid process. This side will be optic So if there is no paraclinoid aneurysm, you can bite off this clinoid process. I wouldn't say with impunity, but with a lot of care. Okay, with a lot of care, you can bite off the lateral borders of this clinoid. You can bite off. Now I have designed a new instrument, which I call it the tumor or the bone scoop. It is like a mechanical CUSA, which you can, day before yesterday, we were demonstrating it. It is very easy to scoop off the bone, and if you touch the dura or the vessels, it's not going to do any damage like the bone CUSA, but much more cutting power. So you can literally scoop away the tumor or the bone easily. You can scoop away, and each one of those scoops, the disposable part of the scoop is going to cost you less than $10. So after each case, you can change it. Okay. So now I am drilling off the medial part of that clinoid so that I can see the optic nerve. Okay. I will see the optic nerve, extradural optic nerve. You will see it very soon. Making it paper thin, that is the extradural optic nerve. Okay. That is the extradural, just like what you saw in the cadaver. And then this part will be the optic strut. We will show that also. And then if I go medially, I am unroofing the optic roof. I'm unroofing the optic canal. So this is the lateral part of the optic canal, and this is superior part of the optic canal where I can unroof. And once I unroof it, this is cutting the proximal and distal dural ring becomes easy because I can make a cut from there and come laterally. And this is where the carotid is. So you can see the optic there. Now we are going to peel off the cavernous sinus, peel off the temporal lobe away from the cavernous sinus. See, that's a cavernous sinus. The membrane is there. So this is frontal, temporal, cavernous sinus, clinoid triangle there. Slowly peeling off the temporal lobe away from the cavernous sinus. See, now the cavernous sinus is beautifully exposed. Beautifully exposed. Entire up to V1. In this case, I don't need more than that. So up to V1, in fact, the V2 beginning will be there. So all the way posteriorly, I have taken the temporal lobe away. Temporal lobe is being peeled away. So that will be V2. This is a superior orbital fissure's lateral boundary, and that's a cavernous sinus. That's a clinoid triangle. Can you see, everybody? Can you see? Somebody answer me. Can you see this?
Yes, yes.
Yes.
You see what we did in the cadaver is exactly what we are doing here. Nothing different. We are peeling the temporal lobe away from the cavernous sinus. So that's the cavernous, that is the cavernous sinus. Entire cavernous sinus is getting exposed. Frontal lobe will be going away there, and then you will see the optic and the carotid in this side once I clear that. And if you go more posterior, you will be into cavase. There is no need for that here. Okay. Here I need only a pretemporal root. I have already achieved that, and that is the optic nerve, and that is a strut. Again, I don't need to remove the strut in this case. Okay. Again, although you know everything and you know what to remove and what not to remove, you should tailor your approaches. You should not take out every single thing when it is not required. Okay. Exposure should always be tailored. So that the that kind of stops the cases. I can show you many paraclinoid aneurysms also on this, or some transcavernous exposures, but we've already crossing 1 hour limit. So, and you know, I want you guys to go back and read the Rhotons, and then maybe next time you should come back, and all the guys who've been here, you should share something. Okay, all of you guys should share something. I'm sure Professor Colley is here. I mean, Vlad is here. A lot of you know, very senior neurosurgeons are here, and I'm sure they will also have a lot to share and talk. So, I mean, we would be learning from them also. So I would want them to also come
now,
in and
I
beg your pardon?
There's an 1 hour limit, I suppose, so it's no time to share something.
No, that's okay. That's okay. We have time. If I has time, we have time.
Find
That's
something.
okay. 1 hour limit is 1 hour limit is for me. After that, discussion can go on the entire night. It is learning, so no problem at all. If you want to share something, anybody wants to share something, we will be more than happy to listen and learn.
Okay, Dr. Jayant Gaud asked, is it necessary to open the lamina terminalis during cisternostomy?
Not always, Jayant. I mean, earlier we used to do that, but now we do it only when there is ventricular blood. If there is no ventricular blood, to open the lamina terminalis means exposing the ventricular system into the subarachnoid blood. And we think it is unnecessary. Because if you open the cisterns properly, the brain is going to get really lax. And if you open the membrane of Lilliquist also, the brain is going to be really lax. No need to open the lamina terminalis. But if there is ventricular blood, yes, maybe it's a good idea to go and open the lamina terminalis.
Okay, thank you, sir.
Okay. Let's see. Any other comments, questions? Shiva says, can you quickly review the course of the ICA in this region, please? It was slightly unclear about the vertical and horizontal ICA. Did you get that?
Right. So, yeah, so I will, you know, what I can do is, I will, if he sends a WhatsApp message to me, I mean, many of you have my WhatsApp number. I will send you an article by us. And then that explains ICA codes in a very, very simple way, our classification, you know. So Vlad must have heard it 1,000 times. So Vlad, I mean, many of you would have heard it so many times. I don't know whether Shiva would have heard it, but I can first send, it's a schematic diagram. Also, you know, it also explains in detail about the ICA codes and the relationship of all these things to the ICA. So if you can send me a WhatsApp message, and I'll be able to, John, you can share my WhatsApp number.
Okay.
And if you do that, then I'll be able to share this article with all of you. Nilesh, you also have that article, right? So Nilesh is here in the participant list. You can message him also. Nilesh can give you that article straight away from the WhatsApp.
Is that neurosurgery coach type or your personal?
You mean the classification?
Yeah, no, for Gian, he should contact you through neurosurgery coach.
Oh, well, the thing is right now I just got this office, you know, I just got this office. And I don't have a secretary or a computer or anything. So it's impossible for me to run the neurosurgical coach for at least a couple of weeks more. So once I get people to help me, because right now I'm running everything out of a phone and an iPad. So it's a bit difficult. So I'm just settling in. So once I get my secretaries, everybody in place, then I can go ahead and, you know, start the activities for the neurosurgery coach. Now I see a few more questions. Somebody was asking me, could you show once again the dura cut after penetrating the cavase triangle? Okay. So the dural cut is first, the dura is cut along the base of the temporal lobe, and then you take it to the posterior fossa, and the junction of these two cuts is the superior pitosis sinus, and you clip the superior pitosis sinus or bipolar the superior pitosis sinus and cut medially to the tent, and these are the three cuts along the temporal dura base, along the posterior fossa, and then along the tent posterior to the fourth nerve. Okay, these are the cuts.
Okay.
I think that answers a lot of questions, I guess.
Okay, Warlick, are you there?
Somebody is asked, why do people have made cavernous sinus so difficult for younger surgeons to access? That's because this is neurosurgery, Deepak, and it needs a lot of blood and sweat to go into the cadaver labs after your regular work and learn and then fail in a clinical case, then learn again, then fail, then learn again and fail for many years till you understand something. And when you do that, when you do finally understand, it is mandatory for you to share it. And if you don't share it, that understanding will remain with you, and the other young neurosurgeons will have another understanding. Everybody will have their own understanding, but we will not progress. So I hope that answers your question. Okay. So for me personally, I have put in a lot of hard work to learn about this region after my regular work. Of course, we are all neurosurgeons and we all are busy. But after that, you go to the cadaver lab and learn and read and then do, then fail, then again learn, then do cadavers, then fail again and then learn. And after that, what the concept that you get, you share. Then once everybody's understood those concepts, you go again the next step, more attention to detail, and you go again to the next step. That's how you progress. Huh? Right.
Okay, Warlick, it's time to wrap up.
Yes. Any comments or anything? And we are ready to wrap up.
One question by Dr. Shida said, how can we avoid the stripping of the pericavernous with membranes, as you mentioned during the dissections video?
Yeah, so for this you have to do sharp dissection of the orbitomeningeal band. If you don't do, then you have every chance of stripping that membrane and getting into the wrong plane. So you have to do sharp dissection of the orbitomeningeal band and get into the plane above the pericavernous membrane. So that is how you do it. This is our technique. There is a paper in Asian Journal of Neurological Surgeons, our paper on a bloodless way of transcavernous dissection. There's a paper. I think it's 2018 or something. So you can look at it, and then you can look at our YouTube videos. The whole secret of it is to do a sharp dissection of the orbitomeningeal band.
Okay, is there any other questions from the floor?
I can show a clinoid meningioma, which is actually what Ibe has shown it from the beginning, cutting the meningio-orbital band and anterior clinoid resection. You want to see that? Do we have time for that?
Yeah, we have time. Vibe does.
Yes, Vlad, please.
All right, so let me share.
Please show, Vlad, please.
This is a piece of a lecture from sphenoid wing meningioma.
નથી જોતું, કઈ જોતું નથી. સાંભળો, કઈ જોતું નથી. પાણી નથી જોતું, પાણી જોઈતું જ નથી.
You are screen sharing, but I don't see it. John, something.
I can see that you are sharing it.
You're trying to screen
I can
share.
see that you are sharing.
Yeah, go to the PowerPoint, directly to the PowerPoint. Don't go to Zoom.
All right.
Go directly to your, there you go, there you go.
So we have a 63
Yeah, we can see it. We can see it.
Female. She's got visual deficit on the left eye for 5 months developed, and it's a usual clinical symptoms of anterior clinoid. No remarkable history. This is the tumor, you see it. So it's obviously anterior clinoid tumor. And now let's see the video. This is the pterional craniotomy, and now this is the resection of the sphenoid wing, the outer part. And you come to the deeper, a little deeper to the orbitomeningeal band. And exactly as Ibe has shown, you just cut it. You coagulate the orbitomeningeal artery, which is not a big deal. And then you develop the plane between the 2 layers of the cavernous sinus. You see, this is the orbitomeningeal band over here. This is the lateral orbital wall. This is frontal. And now you cut it. And here, to develop the plane between the 2 layers of dura, is the paramount movement. In all the textbooks, they do it from the orbitomeningeal band. What I found, it's better found a little more temporal and then going backwards to the meningeal band. You see, now I'm developing the plane over here on the lateral wall of the orbit. This is already the cavernous sinus, and then going back to the orbitomeningeal band. Somehow I found it easier a little downwards, not directly on the wing. This is still the whole anterior clinoid there. And now it is the question whether to resect it in meningiomas radically now or not. What I sometimes do, I just break it and keep the tip free, since I'm a little afraid between the adhesions between the carotid and the tumor and the dura over here. It's not uncommon, since the carotid is not really covered by the arachnoid in the extradural space. And then the tumor can grow into the wall and you may rupture it very easily. So this is the dura opening. In ophthalmic aneurysms, I always do it intradurally. It's just a remark. This is frontal, this is temporal, and you just go ahead for the tumor to release the optic nerve. Let's see it in a very little while. This is too high magnification, as Juha likes to say. This is the beginning of the Sylvian fissure, and you just strip the arachnoid from the tumor. You do not cut arachnoid unless necessary. This is the uncus. Here is the olfactory nerve, the tumor here. Now we will glimpse the middle cerebral artery over here. Lateral, we shall go as far as the third nerve. Never cut dura on the lateral side of the clinoid, since there may be the third nerve. It's very close there, and you may either hit him or even directly damage. So always cutting the dura from the tip of the clinoid must be only on the frontal side, to put it mildly. And here we are on dura. You see already the opening. This is the rim between the frontal and temporal, and you cut the dura only here, just opening the dural bands. Now we are already there, and then you unroof the optic nerve, which is running here. We are still lateral. Here is still the tumor. Is it clear what I'm doing or not?
Yes.
It is. Okay, so this is the surgical which was put to the place of the anterior clinoid, and you see here is the remnant of the clinoid, which is still there, left behind. and I resect it now. You see, it's completely free, very small piece, but I just feel somewhat safer that I will not damage anything, and this is easy to resect at this point, not extradural. Now we are already extradural. You see the carotid. We are now, this part is already anterior to the ring, and now it's about time to resect the tumor from all these pieces. You see, this is already very clean. Here is the third nerve, here is the carotid. This is the relinquished membrane, which you do not need to open. It really serves as a barrier of your dissection. And now let's go to the optic nerve, which is probably the important structure here, or the most important structure here. Unless you damage anterior choroidal, you have nothing else to damage in this area. Carotid is a mighty structure which is unlikely to be damaged intradurally. Extradurally, it's quite easy. And now the dura will be cut along with the ring. We know where the carotid is, we know where the optic nerve is, so you may cut it free. Again, the Sagittal from the approach is left here. And now it's rather something which may be surprising at the beginning, that somehow the optic nerve doesn't run away from you here straight, but it's bent, like it's nearly in a way horizontal in a meaning. So you may be aware of that the optic nerve, if you see it intradurally somewhere over here, extradurally it will be over here, because it's pushed by the tumor, and here it goes into its normal and original position. This may be a little confusing. You see that the nerve is running, let's say, transversally to the surgical field. And now here is the optic nerve. Here is the rim, still the tumor being pushed. The carotid, you see all the structures. Again, please note that the whole arachnoid is preserved. It's the best natural barrier, and as Professor Kanan says, it's arachnoid is your friend. And here's the tumor itself, which now is completely free from the skull base, completely bloodless, and you just may decrease it by CUSA, should you wish so, should you need so, and then take it out as it is. You see, the tumor doesn't look that small as soon as you have your high magnification. Now it really is embedded only in the frontal and partly temporal lobe, but mostly frontal. So there is, again, nothing to damage, but it should be completely extra arachnoid dissection. You do not want to damage it. That's it. And now you see the anterior cerebral, middle cerebral, carotid, optic nerve. Here is the olfactory nerve, optic nerve. This is the Heubner's artery. You see all the structures you want to see here. And all this is because you did your extradural cranioidectomy. Then you have lots of space there for everything. You see, this is the whole approach. Now with a little plastics, you just cover the field. And this is after. All right. Vision improved. That's enough of a case. Did it fit to your?
Yes, yes. Thank you, Vlad. Thank you very much. Thank you very much, Vlad. That makes things much more clearer. Again, I suppose for the younger crowd. Is Dr. Colley is here? Is Dr. Colley still here?
Let's see. I haven't seen him.
No, he's here. I can see him.
Okay. He may have stepped away. Dr. Coley is the name?
Well, if there are no more things to discuss, then I guess we can wind up. Voralax can wind up. I hope this has been useful to everybody. And I think Nilesh, my consultant, has shared the classification of the carotid on the chat. Yeah, I think Nilesh has shared that. So the carotid classification, I think that will make things very clearer. So we have a textbook chapter also. I'll try and share that textbook chapter. That is a textbook chapter. Okay. So that textbook chapter is shared. So anybody who wants to have a look can have a look at that textbook chapter.
Okay, thanks for Dr. Ibe and Dr. Benes for the very wonderful presentations and very amazing case and dissections about the anatomies of the cranial base, anterior, middle, and posterior. So if there's no more questions, so yeah. So for the next week, we also have the wonderful presentations by Dr. Victor about the orbit. It will be coming for the next Monday. So thank you very much.
Okay, thank you, everybody. Thank Warlock. Thanks, Hype. Thank you for coming, Vlad. That was great.
Thanks. It was fun. I enjoyed that.
It was fun. Yeah, me too. Thank you very much, Vlad. Thank you, everybody.
Yeah.
And next we see again next time.
Thank you.
Thank you, guys.
Bye-bye.
Bye-bye. Bye-bye.
Very good. Vlad, now, did you go, Vlad? I was going to say that the people that came didn't have to pay for Vlad. Vlad is extra. Hey, Warlock smiled.
Hi, John.
Hey, who's that? Is that who's
Ashad.
that?
Ashad
yeah.
Tariq.
Yeah, how you doing?
I'm good. How are you?
Good, good. Yeah, you made another conference. That's great. You attend
Yeah.
you attend them all.
More and more.
That's great.
I was happy to see Lad again. You know,
yeah,
it's
Vlad,
very nice to see
that was an additional that was an additional plus. That was a surprise.
But he will have the another.
Yeah, Lad is a crowd puller.
Wasn't that great, Warlick's Vlad coming like that?
Yeah, and he also like.
Yes, Lad comes and brings the crowd.
He also have interactions and share the case.
Yeah, that was great. I mean, I wish everyone would do that. That's great. They're doing that. You know what makes it really interactive that way. Everyone contributing. You know, we'll get that way. You know, I think a lot of this is the audience learning how to use the platform. You know, Warlick's. You know, like Vlad is using it.
Yeah, that's a wonderful. Should have quiz though.
Yeah, well, I didn't want to, you know, I asked Ike, but I don't want to, he's busy, you know, I don't want to push him too much.
Okay.
Yeah.
Yes.
Yeah, you know, that would be, you know, the thing is, Warlocks, I can't make up the questions because I really don't know the topic, you know?
Yeah, I got that. So, I mean, so maybe the quiz, like, to make him, not to ask the audience, like, are they understand or, like, you know, tries to go along with him.
Yeah, well, it's part of teaching, really, like having a quiz about what you talked about. You know, that's basic teaching. And this platform, Cahoots, provides us an easy way to get the audience in, participating, because not only will the panelists, you know, have a say or vote or answer questions, but the people, virtual audience that are watching can participate. Do you know what I mean, Warlocks?
Yeah, so next so should I do the next next post about the orbit, right?
About the what?
The orbit, next topics.
Oh,
yeah,
okay.
Next Monday, I guess.
Yeah, well, you know, I usually who gives the lecture next week?
You always tell me the night before.
Oh, no, it's on the schedule. Oh, you don't know it? Let me tell you. Yeah, I know.
Yeah, so Maybe I plan to maybe make it in advance, so like we can.
Now, let me see what the schedule is here. Okay, just give me a second.
For example, like I have, if I am neurosurgeon myself, but yeah, not every part of the brain that I like.
Oh, okay. Yeah, I understand what you're saying. So you'd be willing to make the
Very
course,
nice. Sorry, Chakwish.
right? Is that what you're saying, Orlick?
It's okay because I have a pictures that you sent me last night about the schedule. So
Okay.
I can.
Yeah, let me share it right now.
Okay.
So you see it, and I'll send you this schedule. You see the schedule?
Yes, actually, we should show that. I mean, after the
Yeah,
presentation.
we should have showed that.
Okay, next week. So how about the session that's still blank? So
Yeah, well, they're open. If you want to get one, do you want to get one?
no, I have a endovascular test coming this
Oh, don't worry.
December.
No, don't
So
worry
I will
about
be
it.
fully
No,
like
no, don't worry about it. No, I'll get someone for these topics. Abby always loves to do them. Abby Shah. So I think, yeah, it won't be a problem getting people. Don't worry.
I think posterior fossa its turn. How about Dr. Bennett, because he will talk about the foramen magnum and far lateral in which it will be related.
Well, you know, I asked Lad, but he says he doesn't do neuroanatomy lectures. I was surprised. I was surprised. You know, I don't know. I asked him. Matter of fact, I had him scheduled, and you know, on the day of the presentation, he says, "I don't do neuroanatomy. What do you have me on the schedule?" And he was supposed to speak, so I had to get someone real fast. I don't know who I got, but I think Victor volunteered to do it. I'm surprised,
Okay.
Victor. That was like, I tell you, when you came, it was like Elvis.
Oh.
Is Elvis Presley big in Thailand?
Juha?
No, Elvis Presley.
Oh, yes. Yeah. But I do not remember his songs though.
Well, you know, that's what
like-
Juha's like. He's like the Elvis Presley of neurosurgery.
Oh, really?
Don't you think so?
Okay, I gotta look at the Elvis Presley picture.
Oh, well, you know, no, in this country, he's huge. He's a god in America. In most of the world in music, he's bigger than the Beatles almost to a lot of people.
Oh yeah, I think it's at my dad's age or something.
Yeah, probably maybe in that part of the world he's not, you know, like the Beatles are well known, right?
Yeah, I think Beatles come after Elvis. Yeah.
Oh, okay. Well, Elvis was even before me, so he's old. He's old. It went good. Do you think it went good?
Yes, at least the minimum. I think the maximum about 70 audience is okay, but
That's good. That's good. That's good.
yeah, maybe yeah.
Well, you know, Warlicks, we're going to continue to get stronger and stronger because I'm able to contact people that came to this webinar, you know, and we're building an audience. Do you know what I'm saying? Because people, when you have the emails of people that come here, they already know what the platform is. They're obviously interested, and we'll be accumulating those followers. Do you know what I'm saying?
Yeah.
Yeah. So we're going to get stronger and stronger. So we'll just continue to hopefully put good material like today up. you know, and tomorrow is going to be good. Man, those young neurosurgeons are really excited from Singapore.
Yeah, Singapore. I think that the chief neurosurgeons from Singapore that you
Kate, we mean Kate?
no, okay, chief from Australia.
Yes, yeah, the head.
When.
Yeah.
When.
Do you know,
He's a good friend.
oh, you
Yeah,
know him? You know him?
I think I know him of a couple years ago because we have the boot camp in Myanmar. I think that we used to meet there, but
Okay.
I think he won't remember me. But he sent a poster to the to announce that they have a webinar tomorrow too to the like Thai neurosurgical like society. So, but as we attend last week, it's really successful. Like it's amazing.
Yeah. Yeah, he's very active. He's the head of the big organization, right? Asia, Australian. I think he runs some kind of it's bigger than the ACLS. It's big, but anyways, they're excited, and if you want, you can moderate that. Are you going to be around tomorrow? You can moderate that too if you'd like. Well, think about it. Think about it. Okay.
Yeah, I would love to if I don't have case.
Oh, so, great! Because we'd love to have you too, if you want to do it. If you want to do it, so.
So still here. Is there anyone want to talk to us? No.
I don't think anyone likes us, Warlicks. Everyone's just watching us talk.
You can say hi.
Hey, everybody! You want to talk to Warlicks or me? Anybody in the audience can do it. Well, I think the majority of the people that come just want to be anonymous. You know what I mean? But that's okay. You know, they're welcome to come and just watch and observe. I think with time, people will become more interactive and less shy. You know what I mean? I think. What do you think, Warlicks?
Yes. So I have to use these panels to practice my presentation because I was invited to speak more and more on the big stage like this. So.
Oh, really? Well, aren't you pretty good at it? Like you've done it a long time, right? Presenting and for a crowd, or
normally like present case or topic presentation, but that I told you that I just present and talk. I give a talk about my medical illustrations work. It's a like night talk, but it's very first time.
To what audience was that? Was that a webinar? Was that a webcast, right?
No, it's kind of like a party, like after they give a like big lectures to the freshmen, to the neurosurgical residential.
So was that an auditorium or at a conference?
Yes, something like that. So I don't know how. Actually, I want to. Normally, I'm shy, so I want to be invisible as well as possible. But yeah, I don't know how they know me. So yeah, they know me though. So yeah, they invite me to talk about that. So that I'm out for your permissions to talk about your channel.
Oh, of course, that would be very nice. There's no bad publicity.
Yeah, and I have another talk about this too, like more big stage on this February.
Okay, well, the networking possibilities are unreal with internet. I mean, you can meet Vlad, you can meet Yuha. I mean, really, think about it, Warlicks. A lot of people will never see them in their whole life.
After COVID, of course, I miss travel.
Yeah. Yeah.
I just found the next ACN with Dr. Kato.
I'm sorry.
My mentor I used to stay with Professor Shinimura, he will be there. So yeah, I will attend that. Okay, so I think people still listening.
Yeah, we're so popular, Warlicks. Everybody wants to talk to us. We're in a room with 40 people. Nobody wants to talk to us. We better be careful when we leave. We better check our tires when we leave of the car. Maybe someone let the air out.
Any comment from the panels that you want to suggest us that what we should work more on that, or any
Suggestions.
suggestion?
Yeah. We'll take them. We'll take them.
We should have like the suggestion, like, okay, I should get rid of Walalakshmi. It's so annoying, something like that.
Have you been hearing from people trying to guide their career in art and medicine? Have you heard from them?
I think in US they have kind of like more professional, like you have to go to medical arts school, I believe.
Oh, really? You have to have a degree or something? No, I think most people are freelance. I think if someone likes their work, they just get it. I don't think they care really would you care really where they went to school? I would just care about the art itself, if it's good or not.
I think if you ask me right now, I think it's compares to the endovascular working in Thailand right now. I mean, if I do not have a permissions, maybe it's illegal to do. Even you can do it,
Right. Really?
But yeah, but in Thailand, like for the medical illustrator, but I don't know that they have a rule or something like that. But they have the school to teach that. Yeah.
Yeah. So yeah, it'll work out. Well, listen, Warlocks, I gotta go. But thank you very much, and you're welcome to moderate tomorrow. I'm looking forward to that. They're very excited, and I think Kate likes it, and I think we'll probably end up doing more in that part of the world. You know what I mean?
I used to work with her, and she's really friendly. So yeah, of course I gotta look at them tomorrow, and like the residents, they prepare really nice and update presentations.
Really, they're good, huh?
Yes, like they concise that already, so it's like updates. So, it's like somebody just read some things for me.
Good, great. Okay, that's great, Warlicks. Thank you very much, and everyone else, thank you for coming.
Okay, see you guys tomorrow.
Bye-bye.